children the flexibility and also the variety that they want while planning a meal and deciding the dose of insulin. So quickly we'll go through this case and this will help you understanding the concept even more. Suppose you have a 8-year-old girl who is on basal bolus regimen and the total daily dose for this child is 20 units and the carbohydrate, the insulin carb ratio is around 20 for this child, right? Now, if the pre-meal blood glucose is 220 and the target is 100 and 60 grams of carbohydrate meal is planned, what should be the bolus dose taken for this child, right? So for this child, the total daily dose is 20 units. So first we calculate the ISF for insulin, right? So that is calculated by the formula 1800 divided by 20. This comes out to be 90, right? That means this actually means that for every 90 milligram per deciliter rise in blood glucose level, you require 1 unit of insulin, right? Now we also calculate the insulin carbohydrate ratio, which comes out to be 22.5. That means 1 unit of insulin for 22.5 grams of carbohydrate, right? Now the pre-meal blood glucose is 220, which is high. So the correction dose for this would be, because you know that it's around almost 100 milligram per deciliter above the target. So 1 unit of aspart to take care of the high blood glucose. And for the meal, you would require something like 3 units. Why? Because 20 grams ke liye 1 unit of insulin, for 60 grams, 3 units of insulin. So the total pre-meal bolus would be 1 plus 3 equal to 4 units, right? So this is how we calculate. But always remember that these are only the guiding principles and they all vary with respect to many more things. Okay, so quickly let us understand this concept. So which insulin affects which blood glucose level? So if you are having a bedtime insulin or a Lantus, so that will impact the breakfast blood glucose level, right? Now if you have the breakfast insulin, that will impact the before lunch insulin level. The blood glucose level, if you are using the lunch insulin, this will impact the before evening blood glucose level. And when you are consuming an evening snack insulin, this will impact upon the before dinner blood glucose level, and the dinner dose of insulin will impact upon the bedtime blood glucose level. Okay, so this is how this particular knowledge of which insulin will impact upon which blood glucose level will help you in titrating and adjusting the insulin level. So quickly, the last component that we talked about, that is the physical activity and play. So this is something which is extremely important not only for a child with type 1 but also for any other child. So minimum 60 minutes of moderate to vigorous activity is recommended. But what is important is because physical activity influences the insulin sensitivity factor. So the blood glucose fluctuations will be there and the insulin doses need to be adjusted based upon the blood glucose level. And while the child goes into this kind of a physical activity, very important that the family knows that the blood glucose needs to be monitored before, during and after the activity, and also the nocturnal risk of hypoglycemia has to be emphasized, because the family may just peacefully sleep, but the child might have hypoglycemia at 2 a.m. because the child played a lot. So insulin dose adjustments need to be told to the family in case the child indulges or undergoes any kind of physical activity which is more than usual, right? Usual exercise will be obviously taken care of because the insulin dosage is already being planned. But if the child has an unaccustomed a kind of physical activity which would predispose to increased risk for hypoglycemia, frequent monitoring of blood glucose need to be emphasized. Tell the family about what is hypoglycemia, the definition, and how it needs to be managed, and most importantly, why did the child experience hypoglycemia? That is something which I would say the most important complication which each and every family should know, because it is such a disastrous and life-threatening condition that it actually discourages the family to have a good glycemic control. So the risk of hypoglycemia, what causes hypoglycemia and how it needs to be prevented should be emphasized and told to the family right from the beginning. Also emphasize about the principles of sick day management. This is something I would say a topic by itself, but how insulin dosages need to be adjusted during a sick day is something that needs to be told to the family, because children keep getting ill, the family doesn't know what needs to be done about the insulin dosages, whether not to give the insulin dosages or to give insulin dosages. So first important thing that you need to tell the family is frequent monitoring of blood glucose and insulin dosages not to be omitted irrespective of the food intake, because the insulin dosages will be determined only by the blood glucose level and not by the appetite during illness. This is something which you need to emphasize, because the most important reason why children come into decay is because of the omission of the insulin dosages during sick day. Okay. Again, I would like to emphasize about the need of psychosocial support and education, because this is not an easy condition to deal with. It's extremely challenging, and the coping and survival skills is something that which develops over a period of time. So the role of the, I would say, the diabetes peers, the youth leaders, the support groups, all these things have to be, the family has to be made aware of, because they can help in providing all the kind of psychosocial support which a child would require. So this is the list of clinical evaluation which a child should undergo. Growth and monitoring of the pubertal status has to be done at all visits, because this is one of the most important key objective while managing child with type 1. Okay, so recording the height, weight and plotting it every visit, plotting it on a growth chart and ensuring that the child follows his own trajectory. At each visit you have to measure the blood pressures, examine the thyroid gland, examine all the insulin sites. So what you can see in the photograph is the lipohypertrophy, because the family was using the same site for insulin administration again and again. Okay, also tell them about the important complications, the chronic complications related to arthropathy, neuropathy, nephropathy and retinopathy. Okay, so this is all something which each and every physician needs to do. Also screen for all microvascular and macrovascular complications, the foot problems, the limited joint mobility, skin problems, and growth has to be emphasized at each and every visit. So again, the role of intensive education is something that needs to be, I would say, emphasized each and every time while we are managing, because the families know about it. The families know how and how often these screening needs to be done, the celiac screen, the comorbidity screen, the long-term complication screen. So even the families will come out sometimes, will tell you, okay, doctor, we have not had our screening done for these complications. So it's very important, and nowadays everybody is very aware. So as doctors, we have to emphasize that they have their record books checked, and all these screenings have to be done timely, so that we can identify these complications and avert them at a timely manner. So the take-home messages from this presentation is that a structured diabetes education has to be delivered in a phased manner, and it is something which is a crucial facet of ambulatory care. Providing comprehensive care to a child and adolescent with diabetes involves a committed team, I would say multidisciplinary team, and it has to be done in a structured manner. Blood glucose monitoring, administration of insulin, medical nutrition therapy, growth assessment, and complication screen, comorbidity screening has to be done at a timely manner, and this constitute the key domains of ambulatory care. And the ultimate goal is to ensure that the child grows and evolves into an independent, healthy adult who is not only capable but also confident about managing his own condition. Thank you. If we have time, we can take a couple of cases. Otherwise, I'll be happy to first take the doubts and the questions from the participants. Do we have any questions?
Ma'am, are you able to see the chat box?
Yes, yes.
So scroll down the chat box, ma'am. There are a few queries came just now.
Okay, so somebody has asked about hypoglycemia. Okay, hypoglycemia is something which is extremely important, and the family should be well versed with the principles of management. So first and foremost is how do you define hypoglycemia? So there is something called as clinically alert hypoglycemia, for which we take a cutoff of 70 milligram per deciliter. There is something called as serious hypoglycemia, wherein we have symptoms which are the neuroglycopenic symptoms and the autonomic symptoms, and which are actually life-threatening. And then we have called as severe hypoglycemia, which is at a level less than 54. So why does hypoglycemia occur? It can happen if there is a mismatch between the insulin intake and the meal, if the child has an excessive exercise without adjusting the insulin timings, if the child is having any kind of illness, at that point also we can have hypoglycemia. If there is a mismatch between we have often seen that if we are using a 100 IU syringe and we are using a cartridge which says that the insulin is like 100 IU per ml, and we use a 40 IU syringe to deliver that, the child experiences hypoglycemia. Okay, so this is something which each and every family should be made aware of. And how do we manage hypoglycemia? You can remember a simple rule: for children less than 5 years we give 5 grams, between 5 to 10 years we give 10 grams, and more than 10 years we give 15 grams of rapid acting carbohydrate. So for this you use the glucose powder that is available. You can even use the glucovita tablets. So you administer this dose of rapid acting sugars, and then after 10 to 15 minutes again measure the blood glucose level. If it comes back to normal, you have to see whether the child is scheduled for the dose of insulin, or the hypoglycemia event it happened in between, wherein the time or the schedule for insulin is not there. If the child is not scheduled for insulin, you always have to complement it with a small snack or a carbohydrate meal, which is actually not a meal, but it's like a snack which ensures 15 grams of carbohydrate. So you can give a glass of milk or maybe a small fruit to ensure that the child doesn't goes back into the state of hypoglycemia. And at that point, you have to emphasize that the family has to investigate, that why did the child undergo hypoglycemia and what adjustments need to be made to ensure that the child doesn't have this kind of an episode again. So there is something called as dawn phenomena and Somyagi, right? So dawn phenomena is actually the phenomena that happens in the early hours of morning, wherein there is release of some counter-regulatory hormones that leads to a high blood glucose level, right? So when you check the blood glucose level before breakfast, you would realize that the blood glucose levels are high because of the dawn phenomena. There is another thing which is called as Somyagi effect, wherein I have a slide. I'll just show it to you. Okay. So suppose you have this kind of a meal pattern, right? So suppose you have this kind of blood glucose profile, right? So wherein the early morning blood glucose are high, right? And the bedtime blood glucose are normal. So 2 a.m. blood glucose becomes very important. So if a child experiences hypoglycemia at 2 a.m. and then there is a rebound hyperglycemia at before breakfast, this is what is called as the Somyagi effect. So for this, what you need to do is decrease the dose of glargine so that the 2 a.m. blood glucose are taken care of and the child has a normal blood glucose. The child doesn't experience the Somyagi effect and leading to a rebound hyperglycemia. But in case the blood glucose levels are high at 2 a.m. again, so in that case you need to actually increase the dose of insulin to take care of the dawn effect, right? So yeah, so while we are calculating the insulin sensitivity factor, we have to see that you have two different formulas. So for rapid acting analogs, we use the formula 1800 divided by the total daily dose, and for regular insulin, we use the formula 1500 divided by the total daily dose. And this is actually constant, right? It doesn't vary. The formula varies with the type of insulin. If you have any rapid acting analog, you will calculate as 1800 divided by the total daily dose. And if you have regular, then that will be calculated as 1500 divided by the total daily dose. Okay, then ICR calculation somebody wants me to tell you again. So insulin carbohydrate ratio. So what you need to understand is this is again like a ratio we calculate to see how much amount of insulin is required for the grams of carbohydrate, right? So suppose you have this kind of a meal, right? So you calculate the content of carbohydrate, right? And how much amount of carbohydrate is there in different components of the meal is something that you can look through resources, right? So suppose you have this meal which has 85 grams of carbs, right? Now, how much amount of insulin is required to take care of this carbs? For this, you calculate the insulin carbohydrate ratio. So this is based upon the total daily dose of the child, right? Suppose the child is on regular insulin. So using this formula, 450 divided by 30, this tells us that for 15 grams of carbohydrate, 1 unit of insulin is required. Now this meal contains 85 grams of carbohydrate, right? And for this, you would require something like 5 to 6 units to cover this meal, right? Okay, this is about the insulin carb ratio. Okay, so basal insulin dose. Okay, so one question is regarding the before meal carbohydrate measured, how much time before meal. So you don't really need to measure. You are already, you understand that the child will have his meal, right? Now, just before the meal, whatever components the child wants to act to ensure that the child has a good amount of fiber, good amount of vegetables in the meal. Then there is something which provides carbohydrate, either chapati or rice or even both. Then there is something like a protein component which gives some amount of carb. So dals have carbohydrate as well. Then you can have two different types of sabjis, like you can have paneer and you can even have non-veg which doesn't have any carbohydrate. So you just have to see that how much amount of carbohydrate is there in the meal, and you have to decide how much amount of bolus insulin is to be given, right? Now the difference between the insulin dose and the meal time will depend upon the type of insulin. So if you are using rapid acting analog, the difference would be 15 minutes, and if you are using a regular insulin, the difference would be 30 minutes, right? So that depends upon the type of insulin, not on the amount of carbohydrates. Now, for dealing with hypoglycemia, always remember that you use only, rapid-acting sugars like glucose powder or glucobeta tablets or, something like this, and you're not supposed to use any ice creams, chocolates, or something which the child likes, because one, it is not a time to party. Number two, you always have to give a strong message that the child has, this is something like a medical emergency and needs to be treated only using glucose. And number three, whatever fatty meal you give, that will not lead to an immediate rise in the blood glucose. That will in fact lead to a delayed rise in blood glucose. So if you consume chocolates or biscuits, the child in fact would, time and again try to indulge into activities which lead to hypoglycemia, so that he gets his favorite food or something like ice creams, chocolates. So never use chocolates, ice creams, biscuits to take care or treat hypoglycemic episodes. Okay. So I've already answered this, that 1800 is not for all insulin preparations. It is only for rapid acting analogs. For regular, we use 1500. So I've already answered why sugar and Glucon-D preferred over chocolates, because chocolates have fat. So it will not lead to an immediate rise in blood glucose. And number two, it will lead to a delayed rise. And number three, child will use that opportunity always to party. So he will always indulge into hypoglycemia again and again. So there is nothing like fixed dose of insulin, okay? Always remember that insulin dose depends upon so many factors. I had already talked about them. And when you are talking about the fixed dose of insulin, that will never be able to take care of the pre-meal blood glucose rise, number one. Number two, the kind of meal the child enjoys, right? He will always be given a similar kind of meal every day to ensure that the blood glucose doesn't undergo any fluctuations. And that will actually lead to a lot of craving within the child, right? He will try to eat things hiding from the family, or try to steal sometimes, and he would that will actually lead to indulging into wrong habits. So allow the child to eat whatever he wants, but in a disciplined manner, ensuring that the child enjoys the meal. The entire family enjoys the same kind of meal, and in fact, I've seen after the child being diagnosed with type 1, the entire family becomes very disciplined. If hypoglycemia occurs before insulin dose, should we decrease the insulin dose? Yes. So this is something called as negative correction. If the hypoglycemia occurs before the scheduled time for the insulin, so first and foremost, you treat the hypoglycemic episode, right? You delay the bolus dose till the blood glucose comes back to at least 100 and beyond, and then you can give the insulin dose by doing something like 10% correction. So as we did for a high blood glucose pre-meal bolus, we can do it for a low blood glucose level. So we can subtract something like 1 to 2 units based upon the total bolus dose and also based upon the age of the child. If an insulin injection is injected inside the... So insulin injection has to be given in the subcutaneous region, and it has to be given I would say in the exact the using the standard techniques. There is no remedy for giving it at a wrong site. If you give it at a wrong site, obviously the absorption will not happen, and the control of blood glucose may not be there, right? So that is something which we need to remember. Then if hypoglycemia occurs before insulin dose, what should we do? So I already explained. You first treat the hypoglycemia episode, and then ensure that the blood glucose has risen up till at least 100 milligram per dl, and then we can give the dose of insulin by giving a negative correction. So fruits like banana should be given only and only after treating the hypoglycemic episode. So for hypoglycemic episode, you have to use glucose powder and nothing else, right? But once the hypoglycemic episode is treated, and that is a time which is not scheduled for insulin, it always have to be complemented with a small snack, and that small snack can be something like a small banana or a medium-sized apple or a small sandwich or a glass of milk to prevent a recurrent episode of hypoglycemias. For glargine correction, no. For glargine, we don't have a correction factor. So if you have a child whose blood glucose logs are, I would say he's having a high blood glucose at all times of the day, right? So for that we have to increase the dose of glargine, because if the blood glucose records are very high for all pre-meal blood glucose levels. So this is the last question I'm answering. So this is the case that we discussed. So this is an 8-year-old girl who is on basal bolus regimen, and the child requires a total daily dose of 20 units, which includes Aspart, which is actually a rapid acting analog, and glargine. Okay, and the insulin carbohydrate ratio is around 20, right? Now this child is scheduled for a meal, and the pre-meal blood glucose is 220, right? And we all know that the pre-meal level should be close to 100.